Hi everyone, and welcome. I'm Susan Evans. I'm a practicing member of the governing board and I'm chairing this session. So if you have any questions during the session, please put them in the chat, and at the end, hopefully we'll have some time to answer some questions. So I want to go ahead and introduce our speaker, who is Cinzia Scorzon, who is a Chinese medicine practitioner and a senior lecturer at the University of Westminster. She's also spent time studying in Shanghai, in Japan, and in South Korea. And she's been in private practice since 1984. And just before the pandemic, she conducted this research project comparing CBT, cognitive behavioral therapy, with acupuncture for generalized anxiety disorder. So I will hand you over to Cinzia, and really looking forward to this, Cinzia. Welcome.
Okay. Thank you very much. Thank you for inviting me, first of all. Before I start, I just would like to acknowledge a few people who actually were very important for this project to take place. One, of course, was Mark Bowey, who was the ARC founder and the actual holding column until recently that he has retired. And then there are other few people. One is Dr. Amanda Redvers, who is a psychiatrist that works on the NHS, but she also did the acupuncture training with us at the University of Westminster quite a long time ago, who was very kind to give me quite a lot of advice, and right at the beginning, because I didn't know how to do this, quite honestly. Yeah, I think Mark encouraged me to go ahead with this project. He thought it was a brilliant idea, but you know, the nitty-gritty of how to do it, you need somebody who is experienced, you know, who has done research, this kind of clinical research, who can at least point in the right direction. The other people I would like to acknowledge, one is Arnold Dessa, who used to be a lecturer at the University of Westminster and a practicing acupuncturist, and he helped me to recruit patients because he used to work in the Fitzrovia medical practice. It's a GP practice, so he helped me with that. I would like also to thank Felicity Moyer, who was the course leader at the time, and she supported me through the whole process of this research, and of course Volker Scheid, who is my husband, and he has been supporting me as well, and he has got a lot of experience in both clinical and academic research. Okay, so I am not going to talk about anxiety because you all know about it. Yeah, I just am going straight into the study because I think it's what you want to hear about it. So this study, can you click, Anna, please, the next slide? This study comes after the original one. There was in 2016, there was a study that was organized by the BXC and the Anxiety UK, the charity. Yeah, and the aim of that study was to see if acupuncture could be added to the other therapies, yeah, the non-drugs therapies, to address this problem, to address anxiety. And I contributed to that study. I saw quite a number of patients who were referred by Anxiety UK at the time at the University Polyclinic. And the outcome of that study was that acupuncture was added to the list of therapies which could treat GAD, generalized anxiety disorders. So after that, the BXC actually awarded me a grant to do this study. So what this study consisted of was to compare the treatment of anxiety, compare CBT, cognitive behavioral therapy, with acupuncture. And it was obviously a small study, Yeah, it wasn't a big study. It was a clinical study, and we wanted, with this, I wanted to demonstrate or to find out basically whether, first of all, recruitment and the kind of attendance where people, were the study could retain the participants, and then evaluating the effectiveness of acupuncture in comparison with CBT, and then safety, of course, was assessed as well, safety and side effects. And so this is basically what the study was about. Can you click, Anna, please? So the method was to recruit, we went for a number between 20 and 24 patients, and we were dividing them afterwards in two groups, in two arms, one the acupuncture and one the CBT arms. They basically what can I say? It was the degree of anxiety, let's put it that way, was according to the NICE guidance of step 1 and step 2. Can you please put the next slide, Anna? Because here it is. These are the two, step 1 and step 2 in NICE. Yeah, so you can read it. So we are not talking about people, who were severely suffering from very severe anxiety, who were on very heavy duty medication and things like this. So that was what we did. And can you go to the next slide, please? The inclusion and the design. So the most important thing was the participant, needed to have a letter, either from their GP or from a counselor or from a psychoanalyst or from a complementary medicine practitioner, obviously registered with the professional body, confirming that they were suffering from GAD. We didn't take anybody who self-diagnosed themselves with GAD. Okay, they were excluded from the study, and all the participants were over 18 years old. They actually didn't have acupuncture prior to 6 weeks before the study began, and also they didn't have CBT, of course, because of that. Yeah, if they were on medication for anxiety, yeah, it was okay, providing they didn't have any change of medication. That basically they were staying on the same drugs. Yeah, no change in dosage either. Okay, and we didn't take any pregnant woman, of course. So this was the inclusion. And the participant, we managed to recruit 26 people, but 2 participants, after they heard they were allocated to the CBT arm, they didn't even come from the initial consultation. They didn't give us any reason or anything, but this is what we suppose. I mean, I was receiving all the emails of all the possible participants, and I could, a lot of people, they thought they could choose which arm they could join. They didn't understand fully that they would have been randomly allocated. That is a problem when you do these studies. Yeah, the people, participants get all excited, but then they want to choose where to go, and that would be a bias. So I had to explain to them, I'm sorry, And this actually caused major delay, because I had quite a lot of inquiries, but a lot of people, when they heard that, they just said, oh, I'm not interested. So that was another, you know, there are a lot of problems. I will, while I go through the description, you know, what happened, you know, that was a problem anyway. So the kind of, how did we recruit people? We just put, you know, email through the old university campuses of the University of Westminster, and then we also got in touch with nearby university, Birkbeck, UCH, and SOAS. And then I wrote to GP practices in the area, and let's see, basically, and then I put leaflets, you know, I left leaflet in places where students were hanging around. But funnily enough, we didn't have an awful lot of students responding. There were people coming from different section, you know, there were people referred by GP practices, people referred by counselors, you know, psychologists, people referred by a couple of acupuncturists, Chinese medicine practitioners. So it was, and also the age of the period of the people who participate was quite wide, which was positive, was very, very good, actually, I thought. Okay, can I have the next slide, please? Okay, so these people were divided in two groups. At the end, we have 12 people in each group. And the measurement was done through two questionnaires. One was the GAD-7, which is the standard one, yeah, that is provided. It's used in the NHS to measure anxiety. And the other one was the MyMop. Are you familiar? I suppose you are all familiar with that, yeah? Measure yourself medical outcome profile, yeah? And the GAD-7 was given on the initial consultation, then on the fourth consultation, and on the last consultation. Instead, the MyMop were given to every session. So it was different, you know. I chose to have two, not just the GAD-7, because I found the GAD-7 extremely limited. And also, you know, I wanted to have some sort of idea of what was happening after each treatment episode. The sessions that patients received were 8 in total. Because in the previous study, the one, you know, with the anxiety of UK, we were allowed, actually not advised, to give only 6 sessions. And I found the 6 sessions were not enough. So I increased a little bit of the number, and we agreed to 8 sessions. And this is so we could have quite a bit of information, you know, gather quite a bit of information on the progress of the treatment. And so that is basically it. The practitioners were only 2 people. One was myself, and one was a colleague of mine who is a psychotherapist, a counselor, specialized in treating anxiety. And she's a member of the professional body, the Association of Counseling and Psychotherapy. The sessions were given at the University Polyclinic, so that it was the same room in both cases, in both treatment. And both of us gave not just treatment, but also lifestyle advice. So we talked also about, you know, ways to somehow manage the anxiety, exercises, diet advice, and things like this. So it was very much, you know, very similar. So can I have the next slide, please? Okay. So this is the GAD-7 questionnaire, if you're not familiar, yeah, with the different symptoms and the numbers. The scores, obviously, you know, were between from 5 upwards, and they have this kind of representation, okay? So this we have already talked about. Word of mouth, I forgot about it because actually we had a few people who actually told other people to come and eventually, you know, over the month. It was very protracted, this study, before I forget. It went on for a long time from 2018 March until December 2019, because my colleague, the psychotherapist, had a terrible accident. So she was unable to work for over 4 months. She couldn't travel, you know, after the accident. So basically her arm was, you know, suspended for all that time. That could explain also the dropout of quite a number of the patients that she saw. Yeah, it's unfortunate, but you know, things happen, and there was nothing that could be done at the time. So I forgot to mention it. Okay. The sessions that we both gave to patients, the initial one consultation was 1 hour, and it included treatment, in my case with acupuncture, and the follow-up session were all between 40-45 minutes. Okay, also with the CBT. So you know, we try to make it as similar as possible. Can I have the next slide, please? Yeah. No, I think it's another one. Yeah, here we are. Okay, I have already, oh yes, the recruitment. Apart from the letter confirming they suffer from GAD, the other problem was when the study was conducted. It was during working or studying lecture hours. So that was another issue, you know, for potential participant of not being able to come. Yeah, and then there was the issue that they didn't want to be allocated, you know, to the CBT group. Funnily enough, none of the people, you know, allocating the acupuncture refused to be allocated in the acupuncture group, believe it or not. They all, you know, stayed. So that it was interesting. So obviously, you know, people were looking for something different, I think, for something either because they already had the CBT or because they just were curious and wanted to see, you know, what is this acupuncture. So that was quite interesting. You know, that there was a very welcome acceptance. Actually, it wasn't acceptance once they were allocated to the acupuncture group. We didn't have any dropout at all. Okay, but I'll talk about the result. In both arms of the study, there were no side effects reported. Yeah, nothing at all. So that was all the thing that we were evaluating in the comparison. Okay, next one, please. The results. Okay, next. The retention of the CBT group. Can you see that? So we have 2 people who didn't turn up, not even for the initial consultation. 2 people, they only came for the initial consultation, then they said they didn't want to come anymore. And then we have only 1, 2, 3, 4, 5 people who completed all the 8 sessions. Okay. So there was the one who had 6 sessions. Actually, what happened was that the CBT that the LGP organized came up. So she said, okay, I'm not having twice, you know, the same treatment. So she stopped with us, but the other ones left. And unfortunately, they just canceled, you know, the follow-up session, and they didn't divulge the information. They didn't say why they stopped. Yeah, we couldn't find out. You know, when I gave everybody the participation leaflet with the information, of course, you know, you had to write that the people are allowed, you know, to withdraw whenever they want for whatever reason they want. So, you know, it's part of when you do a study. Okay, next one, please. The retention with the acupuncture group. Only the 12th patient stop on the after 6, simply because she was a student and she was studying Leeds University, so she was a little bit too far away to come for her sessions, so she stopped. If she would have been in London, she would have continued. All the other ones completed all the 8 sessions. Okay, thank you. Next one. Okay. Now we look at the MyMop and the GAD questionnaire. Next session, please. So this is the CBT group, yeah, the MyMop. So you can see there are not, you know, the MyMop. This is all what the therapist managed to get. So for some reasons, you know, some MyMop she didn't take the MyMop of the people who only did 1 or 2 sessions. So this is what she gave me, yeah. And but you can see that the treatment, apart from patient number 6 who stayed more or less the same, there is an improvement. Yeah, can we see the next one, please? This is the GAD, and also with the GAD you can see the same, that there is the improvement. Okay, can we compare with the acupuncture? The next one, please. Here we are. So can you see as well that there is quite, even with the patient number 6 was very high, yeah, even with her there was some improvement. So the different numbers that sometimes they go up, yeah, halfway through or among, is simply because of things happening in the life of these people. And obviously, you know, when you do a study like this, when you measure everything in a very quantitative way, it's very difficult to assess that. But as far as I can remember, one of the participants, she was a foreign nationality. She lost her job and she lost the right to stay in this country. So she actually received a letter from the Home Office saying that basically she had to leave the country. So you can imagine that. Another one had their flat flooded. So they had to temporarily move with their family somewhere else where the council allocated them until they sort out the flat. Another one, the student, 2 of the students, they had mega exam, so they were very anxious. And another woman, for the first time after quite a long period, she had to start a new job going outside. Until then, she was just working from home. So, you know, going out was pretty, you know, frightening. And another one was diagnosed with a new condition from, you know, from a hospital checkup. They found out that he had another condition. So there were circumstances, you know, that actually, this is why the anxiety increased, you know, and is reflected in the MyMop. But they all said that they were surprised how well they managed with the change of circumstances, with these new things happening to them. That they told me, oh, if it happened before having this treatment, I wouldn't have coped so well. So that is important, you know, and I think in the future studies should definitely have some sort of qualitative aspect, because this is very, very important to underline this kind of information. Okay, next slide, please. And this is the GAD score, so you can see the score of the GAD as well. That is pretty much the improvement. Okay, so okay, next slide. Okay, we said this, there were no side effects. Next one, please. Okay, so I am not going now to talk about what I did with all these patients, you know, because first of all, I am not a person who follow protocols. So I didn't use any protocol, or, you know, that it might be advice in textbooks or in article, etc., etc. I simply, took the case, diagnosed and treated according to what it was, the patient main picture. And I just put a number of patterns here just for your information on what I found out. So obviously, hitting the heart was the most common, but there were other ones as well that came up. Yeah. The other thing that I would like to also say is that I didn't do the same treatment on the same patient, whether it worked or not, because it's not the way I work. So if the patient, every treatment session, I just do whatever the patient needs in that moment in time. And so I cannot, basically, this is why I cannot come up with a protocol to treat gut. I'm sorry about this, but I would feel that I am actually using East Asian medicine if I did that. So this is basically the pattern. Can I have the next slide, please? Okay, next one. Okay, so the discussion, yeah. So I've already told you that about, the acupuncture, that the retention was very high with the acupuncture arm. Next slide, please. Okay, the results as well, you saw for yourself in both the GUT-7 questionnaire and the MIMOP. They were very much similar in terms of the outcome of the CBT and the acupuncture. Yeah. Next slide, please. Okay. And other things that I would like to add to what I did in the study for the acupuncture. I cannot tell you about the CBT, I mean, she just used, CBT and this is it. But because I'm presenting to acupuncturist, I would like to talk a little bit more of what the treatment consisted in. So what I did was changing the combination of points for most of the treatment, with the same patient, even the same patient at different point combination. The insertion of needles, the depth of the needle was more superficial because I studied with Japanese practitioners in Japan. And one of my teacher was actually somebody who was specialized in treating anxiety and mental health disorder. And he actually said, he said, well, I don't think it's a very good idea with people suffering from anxiety to do a very strong needle insertion, getting the chi in a very strong way, because they tense up even more. They're very sensitive, So if you have a shallow and as painless as possible insertion is better. Sometimes you don't even, you just stimulate the point without insertion. And I did that. And actually in my practice, I found it by myself that people suffering from anxiety is better, to be very, very gentle. I always use sarin needles, very thin, 0.16. And then I didn't use, with all the patients, I didn't use manipulation. Only with the ones who had, I had 2 or 3 of them, they had some sort of muscle tightness. So, I did a bit more, but they asked me to do that. Yeah, I negotiated with them. But otherwise, for their anxiety, there was just, a very subtle, gentle needle insertion. Retention of needles as well. I went for the pulse change. So sometimes I was 10 minutes, sometimes less than 10 minutes, sometimes 20 minutes. And I always check both the pulse and the tongue. And I check it regularly throughout the treatment and see how it changes. And their breathing as well. Yeah. Some of them fell asleep, so that was great. I thought, it was a bit of a job to wake them up, but never mind. And let's see. basically. Next slide, please. The slide. Okay. So what I hope is, apart, the conclusion is that acupuncture, it was very much, a very much similar effect to CBT, and people found it very useful. I had some very interesting, I asked actually the patient I saw, I asked them to write down at the end, of the last MIMOP, a comment, just, one line about the treatment. So most of them, they wrote, just a sentence or something about what the treatment did for them. I'll just read you just a couple. One said, my condition has benefited from the treatment because it has reached to the root of the problem. I wish I could have had more sessions. Another one said, I am very thankful for the treatment I received. It made me feel a lot better. I wish I could continue. So they really liked the treatment. Another one even said, acupuncture treatment has been life-changing. My anxiety level have been greatly reduced. So they all wrote, very positive. They gave me positive feedback, and it was very nice, to see, because sometimes when you do things, treatment, when you give people treatment for free, I don't know, I did it in the past. Either people stop coming, they don't turn up, they are late, they turn up the wrong day, or they simply, they don't say anything, they don't. But this group of people I treated, they were very, very appreciative of the treatment they received, and they found it very, very beneficial. So it was great to work with these people. I really, I should have acknowledged all these patients, but I cannot mention them because of GDPR. But I thank them greatly, for having actually participated in the study. I think we have to finish. The only thing that I hope is that one of you young people, one or two or three, do a much bigger a study with a lot more participants, because especially now with COVID, and with all the increase of mental health issues, I think that acupuncture should definitely be put on the map of the treatment that people can have access to. Yeah, like in other countries, there are countries like Switzerland, for instance, yeah, where people can choose to have acupuncture or Chinese medicine, yeah, as well as conventional medicine. So I really hope that some people might be inspired to carry on this, please. Okay, thank you for listening.
Fascinating, Cinzia, really, really good. A couple of questions here in the chat box.
Yes.
So the first one was from Christine Grabowska, and she has asked, do you know the difference in the cost between CBT and acupuncture? Which is a very interesting question. I mean, I can sort of answer that from my perspective. Yeah. I'm the CBT therapist as well. CBT is much more expensive than my acupuncture treatments. The CBT therapist will charge a lot more than I will. So I would have thought acupuncture might actually be more cost effective.
I think that London, I heard from people, is around £120 per session.
Yeah.
Yeah, something like that in London. I don't know outside London, but it's quite expensive. Yeah. Acupuncture varies. It depends, on people, what they charge, but it's definitely cheaper, much cheaper.
Yeah, I would have thought so. Yeah. So another question. Thank you, Cinzia. This is very interesting. Was this a combination of Japanese and TCM acupuncture styles you used?
I don't know how to reply to that, because I don't follow one or the other. I've been practicing for almost 40 years. So I've developed my own style, which, of course, there is a lot of Japanese influence, but I'm not doing meridian therapy or other form of Japanese acupuncture. I'm not doing TCM. Yeah, so I try to use the least number of points as possible, because I think You don't need to use a lot of points unless, you know, there is a request for that. So I don't know what to say. Obviously, you know, because I studied all these different systems, my style, I actually put together all this. Yeah, I put together. It's like having a toolbox. Yeah, you have a toolbox, and when you have a problem, you take out the tool that you need to fix that problem. Okay, so the more tools you have, and the more you know your tools, the better it is.
So Joe Penfold wants to know, was there any male or female variance in the retention rates for the CBT treatment?
I don't know, because the CBT practitioner didn't tell me this. She didn't tell me the gender.
Okay.
So I cannot answer that question.
And what about with your patients?
With my patient, the girl it was a girl, the one who went after 6 treatment because she was outside London. So, but I had more women, of course, as patient than men. Yeah,
interesting,
as usual.
Have we got any more questions? If you want to put it in the chat box, because I can't see everybody. So if there's any more questions, please print them. I'm going to say that was just so interesting. What I loved was the fact that your patients got 8 treatments, and the difference that it made on the MyMops from the 6th treatment to the 8th treatment for a couple of them was really huge, wasn't it?
Yeah, yeah.
So I mean, and I think, you know, so many research projects, especially, you know, it's 6 treatments, isn't it? But I think definitely the 8 is really useful. So I'm really glad that you were able to do that, because it has made a difference to the results, hasn't it?
Yeah, but some people were really seriously suffering from GAD for a long period of time. And the ones who said, well, I wish I could have continued, I think we would have got very good, excellent result if we could have gone to 12, for instance. But you know, but you cannot in a study, you have to limit at a certain point.
Yes.
But the other thing that would be interesting to do longitudinal study as well. So to see, you know, over a period of time, but that obviously requires funding, but that would be a very useful one.
Yes,
I think for something like anxiety, definitely.
Yes. Yeah. There's lots of really positive comments here in
oh, I'm glad.
Chat box. Everybody's really enjoyed your talk, and I mean, it is really fascinating. And I think you know, there's one here. Thank you, Cinzia. It must have been a really affirming process for everyone involved, and I'm sure it was. You know,
it was touching. It was really touching, you know, because that was before COVID. People hugged me. They brought me present or left present at you know, in the polyclinic for me, cards. You know, it was unbelievable. You know, I thought, wow, it was really nice. Actually,
I mean, that's the wonderful thing about doing a MyMop study, is that, you know, when you get the results, they're never quite what you think. They're always so much better than you think they're going to be.
Yes, yeah. No, so, it was nice.
Yeah, so thank you so much. Really, really appreciate that. That was
thank you very much to everybody.
And yeah, it would be lovely to see other people pick up the baton, wouldn't it, and do a bit more study on this, because it's really, really worth.
Yeah, I think we need it. I definitely think we need it. I will write an article, hopefully, you know, and when I have the whole chunk of time to do it, and it will be on EON, you know, in the journal.
Brilliant. We should look forward
in the future. Yeah. So there will be more details about the study. Thank you.
Yes, thank
you.
Bye
to everybody.
Very much. So that's the end of our talk. I think.
So I can leave the room and join the main one?
Yes, you can. Yes. Thank you very much, Cinzia.
Bye. Thank you for sharing.
So we now move into breakout rooms. So at the bottom of your screen, you will see the breakout rooms. So if you want to click on the breakout rooms and then choose the breakout room you want to go to next. So thanks for coming, and see you later. Bye.